Hi, this is Elliot Fishman, and welcome to part 5 of our detailed talk about hepatic masses with a focus on signs and enhancement patterns that allow you to make a more specific diagnosis. In the last lecture, we spoke about hepatic adenomas and the overlap with hepatomas. So what I'd like to do in this part is really look more carefully at hepatomas. There's about 42,000 cases a year in the U.S., about 30,000 deaths. It's about 5% of cancer deaths. 5-year survival is about 22%. The age range, median age of diagnosis, 67. So you can see it's an older population, but kind of that classic cancer population. Age 65 to 74 is indeed the peak. The percent of liver and intrahepatic bile duct deaths is highest among that 65 to 74 age range, which is not surprising because there's only a 22% survival, and if you're getting the tumor 65 to 74, that's probably when you're going to meet your demise as well. Now, how many people survive 5 years or more with hepatoma? And I mentioned 22%. That number is getting a little bit better. New chemotherapy, new immunotherapy, new treatments. So there is hope that we can both decrease the frequency of hepatoma, but also patients who get hepatoma, we can increase survival. What do hepatomas look like? Well, without looking at any images, I would say there's a mass in a cirrhotic liver that's very vascular. Is usually infiltrative, but it can be well defined and has a pseudocapsule. Like this case, we see a dominant right lobe mass. On MIP imaging, the neovascularity is very well seen. The feeding vessel of the hepatic artery leading to this neovascularity, again, very well seen. That pseudocapsule is really appreciated on the cinematic rendering. And as you wash out the lesion, as you go from arterial to venous, that pseudocapsule still remains. I remember way back when in CT, people would say, oh, the lesion is very well defined. This can't be a hepatoma. And of course, we learned that hepatomas have pseudocapsule. It does not mean this lesion pops out when you go to surgery or it has negative margins. It's kind of, sort of in some sense, what I would call a pseudocapsule. Now, when we speak about hepatoma, we always think about hepatitis B, hepatitis C. And again, if we can decrease the frequency of patients with hepatitis, we'll decrease the frequency of hepatoma. When you see a vascular lesion in a normal liver in a healthy patient, and it's small, I always think about hemangioma. When I see a vascular lesion in a cirrhotic liver, whether the lesion is 1 centimeter or 3 centimeters or 5 centimeters, I'm always thinking hepatoma. And here you can see a markedly cirrhotic liver, large varices, splenomegaly, vascular lesion. That's a hepatoma. You can see it nicer on the MIP imaging. It's vascular, and again, most hepatomas will be vascular, but not always, because often when they get larger, they're necrotic. You can see the irregularity, you can see the feeding vessels, you can see that there's portal vein involvement. When you see portal vein thrombosis, yes, you can say cirrhotic patients can get portal vein thrombosis, but when I see a mass with portal vein involvement, I'm always thinking about hepatoma. You can see the large varices here. Another mass, very vascular lesion, left lobe of the liver, maybe a little bit of cirrhosis. This does not have the enhancement pattern of hemangioma or FNH or even hepatic adenoma. This is a hepatoma. If this was a younger patient, I would have said fibrolamellar hepatomas, which are very vascular, often with central scars. You could also say metastatic disease. If you said this was a metastatic neuroendocrine tumor, I probably wouldn't be very surprised. But look how vascular this lesion is as I show you a range of images from the lesion and that large area of central necrosis that persisted as we've gone from arterial to venous imaging. And again, that central scarring, the lesion is less well seen on venous, but still well defined. And the scarring probably represents some areas of necrosis or areas of prior bleeding. So that becomes very, very important and you really can't overestimate the importance. And again, here's the lesion. So remember, vascular mass, central scar. It's a big differential, but with the vascularity we describe, that's going to be a hepatoma. Or in this case, elevated liver functions, cirrhotic liver, there's neovascularity in the left lobe, there's a mass with neovascularity in the right lobe, there's portal vein involvement with cavernous transformation of the portal vein and this 8-centimeter right lobe lesion. Look at the portal vein and look at the invasion. Now, what gives you invasion of the portal vein? It can be non-malignant. You can get it from cirrhosis. But when the portal vein's dilated, you could say cholangio is a possibility, but hepatoma is more likely. Hepatic adenoma doesn't do this. Metastasis occasionally will. Lymphoma can do it as well. But when I see a cirrhotic liver, neovascularity, invasion of the portal vein, within the thrombus in the portal vein, prominent vessels, to me the diagnosis is a invasive hepatoma. And here's just a few more MIP images, really nicely showing you the extent of the lesion, and the venous phase also showing you the lesion very nicely. So again, in terms of detection, I think hepatomas for the most part will be seen easily on both arterial and venous phase imaging. With dual phase imaging, you can stage better, determine vascular involvement, determine neovascularity. On very small lesions, you may only see them on the arterial phase, as sometimes they become isodense quickly. And again, hepatoma with portal vein extension and neovascularity. Another example, you see the portal vein, you see thrombus, you see cavernous transformation. And yes, you could say maybe it's just from cirrhosis or it's pancreatitis or something else. But with all of that vascularity, I need to worry about hepatoma. And when you scan upward, there's a large, complicated mass in the liver with central necrosis. And this is classic for hepatoma with portal vein thrombosis and portal vein involvement, as nicely shown on the images. Again, this case gives you both the central necrosis of hepatoma as well as a pretty good pseudocapsule. This is also well shown on the cinematic rendering where the mass with the central necrosis also nicely defined and that pseudocapsule also well defined. Now, this patient has fatty infiltration of the liver and NASH. There's increased incidence of hepatoma with NASH. This is why some of the new drugs for treating NASH become so important, because they can prevent development of hepatoma. When you have fatty infiltration of the liver, it's often challenging when you're looking for METs or even hepatoma. You look quickly at the hilum of the liver and you wonder, is there something going on here? If you look a little bit closer on the venous phase, there is indeed a vascular lesion. It's not just simply textural change. There's a mass present there, and that was a hepatoma. There's some nodes in the portal caval space. And as you get delayed phase imaging, you can see the lesion is subtle. The liver is not normal. The lesion is not isodense to liver, but it can easily be overlooked. Here it is on the coronal views with volume rendering. There's the mass right here. So it can be tricky. You need to be very careful, which is one of the reasons why people do miss hepatomas occasionally. Another example, I mentioned before arterial phase imaging is typically better. When you look at arterial phase in this patient, you see what looks like infiltration, and you do realize there's a mass present, but the mass is better defined on the venous phase imaging. Its borders are clearer. This is a hepatoma. So some hepatomas, the infiltrative nature and the borders are difficult to define on the arterial phase imaging, but on the venous phase imaging, it's easier to see. You can see the patient's vascularity. You can see what looks like areas of neovascularity and perhaps multifocal hepatoma, which this indeed was, with a dominant mass but other smaller masses. You can see this grows toward the porta hepatis as well. The cinematic rendering, again, very helpful. We have not written an article, and maybe we should, looking at the accuracy of cinematic rendering in detecting hepatic masses, specifically hepatoma, compared to routine axial and multiplanar CT. But you can see nicely on the cinematic the neovascularity of the tumor, as well as its borders and large size. So again, hepatoma. Another patient with weight loss, large mass left lobe of liver, and what may be some satellite lesions. Again, the tumor is not very vascular, though the borders are vascular and there are perfusion changes. When I look at this, the only thing I'm thinking about is malignant. Is it hepatoma? Is it a cholangio? Is it metastatic disease? The hepatic artery is splayed. There's vascularity around the edge of the lesion. Again, you look at it, it's a large mass. Could this be anything else? No, it's not hepatic adenoma. No, it's not FNH. No, it's not hemangioma. It's not a simple cyst. I guess maybe on these images, I could say biliary cyst adenocarcinoma. That might be a thought. But when you look at the full set of images, hepatoma with additional satellite lesions is going to be the most likely diagnosis for you. Now, sometimes it's challenging. Here's the liver. There are multiple low-density lesions through the liver. The liver is cirrhotic. There's extensive ascites. We know the patient has liver disease. You can see it. The question is, does the patient have hepatoma as well? I think when you have significant disease in the liver, particularly when you have cirrhosis with multiple low-density lesions, it can be difficult to ascertain whether everything you're looking at is parenchymal liver disease or you're missing a hepatoma. It really is a challenge. You can see it on the late-phase imaging. It almost looks like multiple tiny hamartomas, but it's really infiltration of the liver by severe hepatic steatosis with parenchymal liver disease. The vessels are stretched. There's no specific one place of tumor neovascularity. And again, I think it's a challenging case. This patient had MR. They eventually had multiple biopsies, and this ended up being hepatitis in an HIV patient. So we talk about hepatitis, we talk about cirrhosis, and the increased incidence of hepatoma, but not everybody has hepatoma. But a lot more people have parenchymal liver disease. So it is a challenge, and the use of CT and the use of MR and in select cases ultrasound can be very helpful in making this distinction. Now, when we look at different types of hepatoma, one that sticks out, particularly in younger patients, usually women under age 40, is fibrolamellar hepatoma, but it's 1% of primary hepatic malignancies. Serum alpha-fetoproteins are not useful markers in the fibrolamellar, so that's important. Fibrolamellar hepatomas are often very large. They're very vascular. Here, the lesion on arterial phase is not that vascular. It looks very similar to the routine hepatoma I showed you a few minutes ago. And on pathology, this was a fibrolamellar hepatoma. Again, the patient was younger, but still, we knew it was a mass. We knew we were suspicious for hepatoma, but the fibrolamellar really was not diagnosed because the lesion has no impressive vascularity. Central scars are also present in fibrolamellar hepatoma, but again, we talk about central scars in classic hepatoma as well as other things. Fibrolamellar hepatoma can also have central calcification, so those all can be helpful findings. So here's a patient, elevated LFTs, multiple hepatic masses. You give IV contrast, you can see the multiple vascular lesions, but they're not markedly vascular. None of them approach the vascularity of the aorta. There are multiple lesions present. Metastasis are a possibility. Multifocal hepatoma is a possibility. This was biopsy and it was fibrolamellar hepatoma. Again, hepatoma was the right diagnosis. To call it fibrolamellar, well, that's why we have pathologists. There's nothing special to me for fibrolamellar hepatoma unless you told me the patient was 25 years of age, and then I would make the suggestion. Again, some of the other articles talking about this article by Mamoni talking about primary malignant tumors in a non-cirrhotic liver. So one of the things that probably does help you with fibrolamellar or to think about it, is the fact the liver is not cirrhotic. Again, you can get hepatomas in non-cirrhotic livers, though hepatomas are more common in cirrhotic livers, right? On non-contrast CT and MR, or dynamic contrast CT and MR, hypervascularity is kind of classic central scarring. But again, from the images I showed you so far, scarring may be okay, but I haven't shown you a hypervascular lesion. Again, fibrolamellar tend to be large, but again, hepatomas tend to be large as well. Calcifications are not very common in hepatomas. So if you give me a large liver mass and you show it's vascular and there's a central scar and it's irregular in this calcification, fibrolamellar HCC would be a good thing to think about. So how often do I see these in practice? The answer is not very often. I probably see them more commonly in conference than I see them in the real world. But here's some classic examples. Very vascular lesion. There are nodes in the porta hepatis. The liver is not cirrhotic. But if you say hepatoma in this case, you're probably going to be right. If you say metastatic neuroendocrine tumor, you might be right. It's not hepatic adenoma, it's not FNH, it's not hemangioma. This is a malignancy with large nodes. And with those large nodes, particularly in the porta hepatis, I really would be thinking a neuroendocrine tumor metastatic to the liver. You can see the distribution of tumor, nicely shown on the cinematic rendering. The large lobular masses with central necrosis, the additional tumor masses within the liver. Again, very nicely shown. And this was a fibrolamellar hepatoma. So again, age, enhancement, calcification, you got to think of fibrolamellar HCC. Again, it's something that's helpful. It's good to think about, but again, the patients will be getting biopsies. Now, one of the challenges with hepatoma, and I showed you some examples already, without a clinical history of a primary tumor and in the absence of cirrhosis, is particularly challenging. Remember, I see cirrhosis, I think hepatoma when I see a liver mass. If I see a liver mass in a non-cirrhotic liver, it still could be hepatoma, but it also could be metastatic disease. Vascular lesions to the liver, I showed you some examples already, but you think about neuroendocrine tumors. Those are the ones that also can bleed. You think about mets from thyroid, renal cell carcinoma, and as I mentioned, neuroendocrine tumors. So here, for example, is a large mass in the liver. It's very vascular, has a pseudocapsule. I'm thinking it's hepatoma. Now again, you think about risk factors from cirrhosis to Hep B to Hep C to non-alcoholic fatty liver disease, family history. All those things might be helpful, but on the individual patient, you're still stuck looking at those images and saying, what is that lesion? Well, let me tell you what we're going to do. Let's stop here and let's start with this lesion and look at how good we are in distinguishing hepatoma from metastatic disease and where there is significant overlap. So with that, let's take a break and see you soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.